Hi, Dr. George.
Hi, Darryl. Good to see you.
Yeah, good to see you. And thank you very much for being part of our conference this year. Can you tell our audience what you do and where you do it?
Yeah, absolutely. Hi, I'm Dan George. I'm a medical oncologist at Duke University Medical Center. I'm a professor of medicine and surgery in the divisions of medical oncology and urology. And I direct the GU, or genitourinary oncology group there. I've been there for 18 years. I see patients twice a week, and then I'm in research and in education the other times. And we run a number of clinical trials in various GU cancers, including prostate cancer. Been part of our prostate cancer clinical trials consortium, a Department of Defense sponsored consortium for phase 1 and phase 2 drug development for about 14 years now, and really active in the field.
So that's super. And, today I want you to share your optimism for the future of prostate cancer treatment, as well as, just your understanding of the extraordinary progress our field has made in the last few years. We want our patients to leave this presentation with a smile on their face. So what can you do to do that?
Darryl, I mean, this may sound a little bit bad, but there's never been a better time to get diagnosed with advanced prostate cancer than right now. In just the last 5 or 6 years, we've made tremendous progress in changing the outlook for patients who are diagnosed with advanced prostate cancer. And for these patients now, where average survival was maybe 2 to 3 years, we've doubled that, in some cases, much greater benefits. And what that means for patients, what I tell patients, is that the therapies we have today in 2021 are already going to help you live longer than patients that ever lived long before with this disease. And they're just a bridge, because by 2023, 2024, 2025, if they're still alive, there are going to be even more advances that they're going to be able to take advantage of. This field never goes backwards. We only go forward. But in going forward, in making this more and more chronic disease, it becomes even more incumbent on the patients to invest in their own physical well-being and health. And we talk about that hand in hand with the treatments and the future developments. Is also, taking care of themselves to make sure that they're strong enough, functional enough, fit enough to benefit from all those future therapies. But I can tell you, I've been in this field long enough that for the first 10 years in this field, I saw very little change from 2000 to 2010. And then from 2011 to 2021, we've seen tremendous change. In the next even 5 years, I think we're going to see even greater changes and improvements in our options for treating patients. And that's what keeps me excited about this.
Let's unpack a lot, because you just hit on a number of things: quality life, maintaining quality life, investing in your health, regardless of your prostate cancer diagnosis, prepping for prostate cancer treatment, understanding what is going on when you first hear the word cancer in your life. So within our support group network, I mean, we used to we try to be lighthearted in trying to describe, treatment plans and such, and suggesting that what you're doing now is really prepping yourself for the next opportunity to do something better. Does that make sense?
Absolutely. I love that approach. I love that, Darryl, because that's exactly how I think about this. Look, and this is not unique to prostate cancer. It's not even unique to cancer. It's aging. When you think about, as we age, what happens? Probably from age 50 on, our bodies start breaking down. We start losing muscle mass. We start losing, bone density. We start gaining body fat. It's a process called sarcopenia. And you may have heard of the term, but it is sort of the natural aging process that happens as women go through menopause, as men go through andropause. We don't call it that necessarily, but it's essentially the lowering of our testosterone in the functional testosterone in our body, or as we age. And so, what you can do to mitigate that is really important. And look, the best treatment for aging is plastic surgery. No, I'm kidding. No, the best treatment for aging is really exercise, diet, and sleep. And if you can keep those three pillars going, we're not going to get younger, but we're gonna hold steady. It's the same thing with prostate cancer. When you get prostate cancer that is localized, we're going to try and cure you. And we're going to try to cure you if you're somebody that's going to live long enough that needs to be cured, and if your cancer is aggressive enough that needs to be cured. If it doesn't, if either of those circumstances don't hold, if your cancer is not that aggressive, or you're not going to live long enough for other reasons, other cancers or heart problems or issues, then we're going to take a more conservative approach and not try to cure you. But otherwise, we're going to try to cure you so you don't die from this disease and have to deal with it. But if your cancer has recurred, or if your cancer is metastasized, or your cancer presents as stage 4 disease, then we're going to be thinking about how to keep your cancer at a minimum disease state, and then how to keep you as strong and functional as possible. And believe it or not, and I tell patients this, that your diet and exercise and sleep will have a greater impact on your survival than any single drug I give you. And I really believe that. I really believe that what you do lifestyle-wise will have a greater overall impact on your survival. Not even mention the quality of life and everything else, but because it's just going to allow us to give you and manage you with more treatments down the road.
Yeah, and fortunately, it doesn't cost very much to bill somebody for a lifestyle intervention. Let's deal with what I'm hearing as the contradiction between the word cure and the proposition of maintaining quality of life in preparation for the next opportunity. And I'll just quickly explain within we've been around for about 22 years. We've got like 80,000 patients through our organization and such. And when you tell somebody you're cured, they're gone. They're barely maintaining surveillance of their PSA. They're barely talking about cancer anymore. They're just like living their life until their back aches. They come back to their physician. The urologist says, let's do some scans. And they have distant metastases because they weren't paying attention. So we sort of say like there's no real cure for prostate cancer because it's not like you're pulling a tooth out and it's gone. What we say is we're going to do something that provides you the opportunity to say there's no evidence of disease. If you were to come to your doctor's office and get scanned and blood tested and do some molecular some liquid biopsy type things, we're not going to see anything. We're not going to find anything. We're going to tell you to go out and play football and enjoy your life. We'll tell you that anyway. But if you tell somebody they're cured, they just think like, great, I don't have to think about this anymore. So, which we think is a toxic kind of way to present. What do you think about what I just said?
It's a really interesting concept, and I'm aligned with that. But I'd sort of, and I don't want to get into semantics too much.
Yeah.
But I'd turn it around a little bit, and here's the way I kind of look at things: is goals, right? And if we have somebody who has localized disease that's aggressive, our goal is to get them free of cancer. Now, free of cancer, cure, you can say are the same thing, but they're really not, right? Because free of cancer means at that moment, you don't have cancer. Cure is implying that it will never come back. And that, Darryl, is really hard for us to predict with 100% certainty. So the better motion is to really say, look, we want to get you free of cancer off of therapy, right? That's our goal, right? And then if that disease never comes back, that's wonderful. If it comes back and we did all the things we wanted to do and tried to do, well, we're not going to regret that. We're going to move forward. What we call that instead is survivorship. And it's survivorship, whether or not that cancer comes back, it's survivorship. And I don't distinguish survivors who are cured from survivors who have relapsed but are living with cancer. to me, they're both cancer survivors. So to me, the terminology here is about survivorship. It's about putting cancer into remission, getting you free of cancer, and then getting you, if we can, off therapy, and then maintaining all the things I just talked about with aging. Because just because your cancer is no longer active doesn't mean that you get a free pass and now you can go to Friendly's ice cream every weekend, and skip the gym and all these other things. I mean, you have to do those things if you want the quality of life in your 70s and into your 80s. And that is something you have to invest in your 50s and 60s. And that's something I try to do. I try to live by these examples myself, because I don't have prostate cancer, but I might in the future, or something else, or whatever it is. I'm going to get sick. We all do. And how you prepare for that now can have a positive impact on how you recover from those challenges in the future. So I don't want to make it sound like prostate cancer isn't special. It is special, Darryl. It's special to me, and I know it's special to our audience. But our mentality about it should be the same, regardless of what health ailment we're dealing with.
Yeah. What sleep is mentioned more frequently in the last year or two than ever before. What have we learned about sleep and prostate cancer as alongside just general health in the last couple of years that's made us talk about it so much?
Yeah, there's a couple of things about sleep that are really important. Sleep is your recovery period. And we think about that from a physical perspective, resting our bodies, but it's a huge mental component to that. Our brain is actually very active during sleep, and it's recovering during sleep. And the brain is probably the most important organ for your prostate cancer well-being, because that's what's going to be your source of motivation to do all the things we talked about, from diet and exercise to your functional well-being, your ability to carry out activities, to your cognitive, function, which is really critical. Because when we have patients that are becoming more cognitively impaired, it's going to limit our ability to treat them, even with our standard base therapies of androgen deprivation or hormonal therapy. So, protecting, investing in our brains as well as our body is so important. And to me, the best way you can do that is with sleep, ironically. You think, well, maybe I need to read more, maybe I need to pick up a new language, or maybe I need to do Sudoku. And all those things are good. But the best thing for your brain is sleep. And so to me, I think, recognizing that and its importance, and the importance of that in your overall well-being of your prostate cancer health is really critical.
With your patients, do you offer like a medication to help with sleep? Or for some people, and sometimes even for me, it's just a struggle. We just wander into the kitchen or to the den and start reading or eating, and and then the sun starts rising and we realize we didn't sleep all night.
Yeah. Well, I was up late watching our Duke basketball team last night, full
Good
to
for
Ohio
you.
State. So I'm not going to talk too much about sleep. I probably didn't get as much as I should. But I think it's really about quality as much as quantity. I mean, research says you should try to get 6 hours of sleep. But to me, it's really about the quality of that sleep. And they've got all kinds of apps now that you can wear on your watch, or you can put in your phone under your mattress, or other things that can help you kind of quantify your sleep, and how much you're moving around and things like that. And look, I don't get very I'm not a big technical guy when it comes to this, but I think for people who like that kind of quantification, that's great. I think just knowing and getting into regular sleep patterns. The most important things that we can do health-wise is have routines. We're all creatures of habit. And the more healthy habits you can build, and sleep is one of them, going to bed at roughly the same time, getting up at roughly the same time. And if you do have to get out multiple times to urinate, to have a routine to that and be able to have a routine to falling asleep, and whether that's, with, a sound machine, or that is a really darkening shades, or, cold rooms or warm rooms, or different pillows or mattresses, all these things, finding the things that help you sleep and then getting into that kind of a routine is really important. And if there are sleeping aids that are needed to help you in that routine because you're getting up multiple times, that's absolutely fine. Again, it's not so much about how you get that quality of sleep, as long as you get that quality of sleep. So, because that's when your brain is going to have the recovery time it needs to heal and not accelerate that aging process.
Yeah, and as an oncologist, I mean, you see people in late stage presentations more likely than early stage. What can you pick out who's getting a good night's sleep and who's not from the way their cancer is presenting to you?
No, I can't. I can't tell you that this is going to change the phenotype of cancer or the biology of cancer. It's probably not. It probably has more to do with the general health of the person, because what it's going to affect are things like your level of activity during the day, your your diet habits, like you said, eating in the middle of the night and things like this. So we're going to see it in other health related conditions. Your cholesterol levels, your hemoglobin A1C, your body mass index and weight. If we do DEXA scans, and that sort of thing, these are all kind of the chronic effects of that. It's not like one bad night's sleep and we're gonna see it in your labs the next day, but it's going to be more the chronic effects of this, and we're not going to necessarily pin it down. I talk about sleep, but these are all interrelated functions. The more you exercise and the more routine you have, the better you're going to sleep. The more stress and worry you have, whether it's financial or emotional or other things, the harder it is to sleep. Having these other issues and functions in your body doing well, the easier it is going to be for you to sleep. But if you're in pain, you're not going to be able to sleep well. If you're having urination every hour, you're not going to be able to sleep well. So you can't sort of just say, okay, let's just focus on sleep. You have to take a holistic view to your general health. And I probably don't spend enough time talking with my patients about all these things because I'm focused on the cancer. But when I do have patients come in who are in survivorship or are in remission and their disease is doing well, these are the opportunities to then go into, okay, well, look, what can we do to complement this? Since your cancer is under control, how are we doing on these other fronts? And to really start delving into what are we missing? And this is why also it's so important to me that we have a multidisciplinary care. If I'm responsible for all of these discussions in all of my patients, I'm going to miss stuff. But if they're seeing my nurse practitioner, if they're seeing the survivorship team, if they're seeing palliative care team, these are all the people that complement the work that I do around the treatment and management of cancer. And that's why that's so incredibly important that we have these kind of multidisciplinary teams caring for you. Don't look at it as, well, I'm seeing that person. I wish I was seeing Dr. George. No, think of it as, I'm seeing that person and I'm seeing Dr. George. You don't need to see me every month or every 3 months. You know that I'm involved in the case. And what's important, if the cancer therapy isn't changing, is all these other things. So that's where this kind of complementary team approach, when we talk about multidisciplinary care, that's where all these things come in. And at Duke, we have neurologists that we specifically work with, endocrinologists that we specifically work with, nephrologists and orthopedic surgeons and spine specialists. All these people kind of help us with, understanding whether it's the well-being of the patient or the physical ailments that are affecting the well-being of the patient to get people back into their routine, back stable. And again, stable is what we're after. No one's going to live forever, but we want you to age as gracefully as you can, not, in fits and dramatic drops.
So with the new treatments that are available, new molecules, new ways to use radiation therapies and radionucleotides and things, and ways to target cancer cells, they all carry some impact on what's typically called quality of life, but it's really about, some folks will feel nauseous, some folks will feel fatigued, some will have dry mouth. You and I are having dry mouth now, perhaps we're drinking so much water together. The idea of sort of wanting a holistic approach, but one that's also impacted by the misery, aspects of misery that novel treatments can impart to a patient. How should a patient understand when to do treatments and when not to do treatments?
Well, Darryl, that's kind of my job. If the patients had all that, they probably wouldn't need me. So thankfully, that's the partnership, and patients have to be open to that discussion, because I have patients that have metastatic prostate cancer that we're just watching, that have very little change in their scans. Maybe the PSA is going up very slowly, and we're okay with that. And now with PSMA PET imaging, we're going to find metastasis in people who we didn't see it in before, millimeter-sized lymph nodes. And that's going to create some anxiety for people. But to me, it creates peace of mind, because it gives me the knowledge to say those are the only places I see it. And if I see that in more lymph nodes and bones, I'm even more encouraged, because those sites of disease carry with them a better prognosis, a longer survival. So to me, this added, imaging information shouldn't be viewed as changing the stage of the patient. It's the same staging that we've always had. Now we can see it. We knew there was cancer there by PSA. We just couldn't see it. Now it gives us the opportunity to follow, but doesn't mean we have to rush into therapy. We don't have to extrapolate our data from our high-risk metastatic patients into our low-risk metastatic patients. We can continue to manage them to maintain that quality of life and save that, more intensive treatments for when we need them. That all said, we have inevitably, patients will progress, and we have patients that start out with higher volume disease. And for these patients, Darryl, the risk of the cancer complications far outweigh the risk of the treatment complications. And here's why. When we do surgery, we do radiation. We can't take those treatments back. Those are permanent effects. But when we do therapies that are systemic therapies, they can be dosed, titrated even, one dose at a time. And it allows us to sort of manage and engage that toxicity so that we don't overtreat these patients and end up with more toxicity than benefit. And that's the real beauty about systemic therapy. It's a pain for patients to have this kind of chronic treatment that goes on and on. But in many ways, it's really the safest approach for our patients, because we can really dose up to what they can tolerate and then stop or break or change doses or frequency in order to manage some of the things that you talked about, like dry mouth or nausea or other things. When I have side effects or toxicities from treatments, I feel much more comfortable, because I feel like I'm in somewhat control of those. When I have patients that have complications from cancer, like nerve compressions or bone fractures or pain, other sites of pain, or loss of appetite, weight loss, and fatigue from cancer, that's harder. That's harder for me to pinpoint. I can palliate. I can use medicines to treat the symptoms, but I can't reverse those as easily as I can the toxicities and complications from systemic therapy. It's not always the case. There are rare cases where our systemic therapies cause some life-threatening, complications and whatnot. I don't want to make it sound like this is, easy work or light work. No, we take a very serious approach to using these particularly cytotoxic therapies, but we do them when we need them, and we do them because what we're really after is preventing the future complications of the cancer that will inevitably bring our patients down in terms of survival and quality of life. So that's the balance. That's what I can help with years and years of experience, helping people to know when that scale is tipping. And it is kind of like a scale. When's that tipping? And I tell people it's a roller coaster, this course of prostate cancer. It is an up and down, long journey that we're on together. And I see them through the highs and lows, and we celebrate the highs, and we get through the lows. And I think it's just important for people to know that the best thing for quality of life for patients is disease control. There's nothing that's going to help motivate you to keep going, to know that your cancer is under control. And then we'll deal with whatever we have to deal with side effect wise to keep it tolerable. When your cancer is not in control and the cancer is out of control, it's just really difficult to have a good quality of life in that circumstance. There's too much uncertainty and worry, and all the other kind of well-being functions that we talked about, go out the window when you don't have disease control. So that's a really important thing. But don't mistake a rising PSA as out of control disease. That's the biggest thing I still fight, but I still educate around is that natural feeling of, my gosh, my cancer is out of control. The PSA is going up. Most of the time when the PSA is going up, we're not having the changes on the scans to go with it. Most of the time when the PSA is going up, it's a precursor to that. And that precursor could be months, even years before we see radiographic changes in some patients. And the pace of it, the level of it, the doubling time, all those things help us kind of gauge it. But rising PSA alone is not disease progression. It's these other pieces that we're really on the lookout for. But that precursor, if it's fast, if it's doubling quickly and things, that will be a reason to act. So we are sometimes proactive, but that's different being proactive than it is if we're actually treating sort of developing symptoms. So these are the subtleties, Darryl, that we talk about in clinic on an individual basis. And I can't, I don't know if we're going to open the phone lines up, but I can't really kind of do that, kind of recipe for everybody. It's really, every case becomes kind of unique at that point.
Yeah, and that's sort of the beauty of the art of medicine, and the importance of selecting doctors not only that know what they're doing, but and most do, fortunately, but that you feel comfortable discussing your case with. In fact, what's the value of a patient's conversation with you for you and helping them?
Darryl, that is everything. People, I don't think people realize that that visit, and it is just what you said, it's a conversation. The physical exam, it's not going to yield much, right? And the physical contact is nice, but even just on a video like this, the conversations that we have are so enriching for me and forming my opinion of the patient. People think, oh, I'm just killing time if I'm asking about their social life or their family or what they did for that holiday and whatnot. But that's information that's feeding into me. How motivated is this person? How, secure and supported and loved is this person? How active is this person? How, how willing and positive is this person to accept the advice I'm going to give and things like that. So there's a lot that I probably don't consciously do it, but that influences my decision process in these conversations. Why it's so important that I know these people. And conversely, it's about trust. And for these people to trust me to be their doctor and have their best interest at heart, they got to know that I care enough to ask about those things about them and to want to know who they are as a person, because I'm not treating prostate cancer. I'm not a prostate cancer treater. I take care of patients who have prostate cancer. And there's a big difference between just pulling out the guidelines for this cancer or that cancer, disease state and regimen and line of therapy and whatnot, and actually treating patients. Those things help us sort of decide what are our options and management approaches for patients with this. But at the end of the day, it's really all those other contexts that come in from that interview process, that discussion like we're having today, that really formulate how, what path we're going to go down. Because those guidelines just tell you one thing, use this or that. They don't tell you how to use it. They don't tell you how aggressively or how long or when to take a break or any of that stuff. That all comes from the experience of the clinician and understanding the patient and listening listening to what the patient's telling us about that. And if we knew what their quality of life was 6 months ago, and we see what it is today, it really helps us understand. If we don't have a relationship with that patient, it's really difficult to come in day one and just tell you this is what you have to do, this is what we have to change, because you don't know them yet. So that's where I think these interviews, these patient visits, are just so enriching, and I find it makes my job not easier, but I feel more confident in what I'm recommending because I really know this person and this is the right thing to do.
Yeah, and it's important for patients to know that it's not something that they're going to experience the first visit, as you just noted. It takes a relationship, the building of a relationship, and that relationship, the tools of creating that relationship are the conversations between you and your patients, or between you and your doctors, and the relationships that patients have in their community, whether it's the grocery store guy or woman, or a spouse and family, if they're lucky to have such a family. The opportunity to understand yourself comes in reflection from others, and that reflection is created by conversations, by speaking to people. uh, this is very good and very sobering conversation you and I are having for people to hear, that medicine, I mean, it's easy to say medicine isn't just about pills and scalpels and linear accelerators and such, but there's 100% truth to that. I mean, you're getting down with your patients, you're grokking with your patients, because from this sort of, there are two people in a room, but you're creating a third entity, and that's the patient doctor relationship, the curing opportunity, the removal of evidence of disease opportunity, but the ability for two people to come together and figure out how to help one person live a longer and happier life. And that's wonderful.
It is. But Darryl, I don't want to downplay the advances that this field has made in the last 10 years and the advances this field is going to make in the next 5 years, because all of this conversation that we're having is because we get disease control. If we don't have disease control, we can't have these conversations because it's about palliative care. It's about just helping patients deal with the misery. It's because our therapies have been so effective, whether we're talking about our next generation androgen receptor targeted therapies, whether we're talking about genetically defined subgroups of prostate cancer that are benefiting from specifically, precision medicine, whether it's chemotherapy, which again is probably more effective in prostate cancer than almost any other solid tumor. Let me just say that statement again. Chemotherapy in prostate cancer, advanced stage 4 prostate cancer, is probably more effective than in most other solid tumors. And the reason for that, we use a single drug, either docetaxel or cabazitaxel, and we use them for not even at their maximum tolerated doses. And we use them for limited cycles by themselves for 6 to maybe 10 cycles of treatment. And in that context, we see dramatic improvement in survival for patients with stage 4 disease, whether that's in the hormone-sensitive setting or even in the metastatic setting. And so to me, it's probably one of the more underutilized therapies in advanced cancers is chemotherapy for prostate cancer patients. I'm a pretty aggressive treater. Now, from our conversation, you might have gathered that, Dr. George is just this kind of holistic, kind of West Coast guy. What's he doing down in Duke? He sounds like it should be out there in LA or something. But no, look, I'm a treater. And I like to treat patients because I'm really about making sure that they can live with this cancer. It's about survivorship. And I can help you survive these treatments because we're not using 3 or 4 chemotherapy drugs at once to suppress people. We're using a single drug, but it works. And helping people recognize that is so key. The same thing I would say with drugs like Sipuleucel-T and radium, 2 very underutilized therapies in the field. And partly that's because they're kind of an atypical treatment regimen. They require, in the case of CPLCLT, patients going and getting this leukapheresis done on repeated bases and coming back in and getting these infusions. And we don't see any PSA change. We don't see any radiographic change. Patients ask me, did that even do anything? And I can't point to it. All I can point to is the data, the phase 3 data to say, yes, for the vast majority of patients, there's a benefit. And that's what it's doing. We can't see it, but you gotta trust me on that one. And we're going to move on. And the same thing with radium. We're not going to see when I give radium a change in that PSA. We're not going to see, kind of a radiographic regression and things. But you got to believe the data that there's a benefit in the selected patients. And then you get to the newer agents. And I think that's where the hope is. If we can get to those newer agents sooner, if we can use drugs like chemotherapy before patients have 6 months to live, then we're going to give the newer therapies greater opportunity to have even a more, substantial impact on their survival.
Yeah, and as we wind this down, I mean, there are two things that I find totally wonderful about living in the 2020s and moving into the 2030s. That we can know the state of a man's health with more more accuracy, for lack of a better word, than we did 10 years ago. I mean, you could scan things. You're not reliant on PSA progression. You're looking at scans and what those reveal. You mentioned PSMA earlier, and there are new things coming down the line. There are also ways to interpret that artificial intelligence is enhancing, so that your eyes, your best radiation oncologist's eyes and intellect may miss or may have new opportunities to understand what a three-dimensional, incredibly microscopic presentation of a disease may be for a patient. I'm not really describing that well, but there are extraordinary things in the very near future that are at hand. Our patients that come to our support groups that are newly diagnosed often sit in the same room with advanced stage patients, and they hear about these new therapies or the current therapies being used, and they ask themselves, why can't I have Provenge, or SIP, why can't I have abiraterone? Why, I mean, if it's working, if it's keeping that guy so healthy, or predictably get another couple of years, why not give it to me now so I could have decades? What do you think?
Darryl, everybody's life is different here. I can't look at my neighbor and say, why can't I have his house or that car or have all that great time off that he has to go golfing, and things like that. I think we have to look at our own spot in life and where we are, and some things are in our control, some things aren't. Your cancer and the type of cancer you have and the stage and the where you are in the risk stratification and how you respond to therapies, these are things that are largely out of our control. We can't necessarily change. But what you can do is make the most of your circumstance. And that's what I try to do. That's why it gets individualized. I love what you said about AI. I'm a big AI fan, but I'm not threatened by that at all. I see that as an aid to me. It's only going to help me when I have my conversations and I have that relationship with patients to have more data to make the best decisions for them. But it's not like a computer is going to have a conversation with patients and come up with, this kind of holistic approach on how we should manage them. It's not, so if it is, then we're in the matrix, or something like this. So, I mean, I'm feeling like this is only good for us, but we're never going to get around the fact that we still need to have relationships and discussions and individualize. And as long as you have that, you don't have to look at the guy next over and be jealous of his response to abiraterone. You can celebrate that. That's wonderful. He won the lottery or whatever. That's great. But you can look at your own circumstances and say, maybe the next therapy is going to be that for me. Maybe that's what lutetium PSMA is going to be for me. Maybe that's what, the PARP inhibitor is going to be for me, because I have this mutation that he doesn't have. And that sort of thing. Maybe it's I have MSI high and my disease has been not responsive to everything else because, gosh, I have a mismatch repair problem in my DNA that now immunotherapy is really gonna exploit. So, it's you just don't know when that next opportunity is going to be and when it's going to be for you. So making, controlling what you can, and then trusting, the people you're working with to help you make the best decisions. And then however it is, it is. I mean, we're all gonna, at the end of the day, I mean, we're all limited here, but you want to, whatever hand you're dealt for this prostate cancer, make the most of it. And that's really, my philosophy for each and every patient. That's why when we have these conversations, and how we treat, I don't know that I treat any two patients exactly the same. If you look at their, histories and everything, by the time we get to metastatic castration-resistant disease, there's probably no two cases that are alike. And I've probably treated thousands of patients.
Dr. George, thank you very much for this conversation. Thank you for the care that you give to your patients. Thank you for the care that everyone at Duke gives to their patients. Several other Duke physicians are part of our faculty, both for this conference and in the past. And Malecare is extremely happy to have a good relationship with Duke. And I'm personally very happy that you took time today to speak with us. Thank you.
My pleasure, Darryl. Thank you very much. Appreciate it.